Good evening, everyone. My name is Bonnie Baker. I'm Executive Director at the Canadian Lymphedema Framework. And on behalf of everyone at the CLF, I'm excited to welcome you to our first episode of Pathways Live, Authors in Conversation. This series brings some of our magazine's most compelling articles off the page and into real-time conversation. It's like a book club for lymphedema care. Each episode will feature the author of a selected Pathways article. Now, you'll notice I mentioned that this is our first episode, but as many of you already know, this is actually take 2 of our first episode. Unfortunately, our first try was unsuccessful after we ran into a technical outage that affected our live stream. So for those of you rejoining us for this second attempt, we thank you for sticking with us, and please cross your fingers that we make it through this time. I'm sure we will. If you should get disconnected for any reason, please know that the session is being recorded and a link to the recording will be shared with you after the live stream has concluded. Now, before I get to introducing our host and our guest author for this evening, I just have a couple of housekeeping notes to share. Prior to joining us this evening, you were provided with a digital access link to the reading materials. That includes the articles we'll be discussing tonight. And we'll place a direct link to these materials in the live stream chat should you wish to reference them during the conversation. I'd also like to take a moment to acknowledge the generous support of our industry partners whose sponsorships help the CLF to deliver great programs like Pathways Live to you, the lymphedema community. Thank you to Bauer Find, Juzo, Essity, Waries, and Medi, to LNR, to Sigvaris, and Lymphology Skincare. Now, without further ado, I'm pleased to introduce our host for this evening, Pathways Editor-in-Chief, Anna Kennedy. Anna is a CLF founding member and the editor of Pathways, the CLF's official publication. She spent 30 years in corporate senior management, working in the areas of training and communication for international companies like Thomas Cook and American Express. Her last business role was vice president with Indigo Chapters before she transitioned into the charitable sector back in 2006. Anna served on the board of the International Lymphedema Framework from 2012 to 2020 and was the CLF's executive director from 2014 to 2019. These days, she volunteers in an advisory capacity to the CLF's board of directors on special project-related activities and, of course, acts as editor-in-chief for Pathways, which is a very big job. Anna was awarded the Queen Elizabeth II Golden Jubilee Medal for her leadership and contribution to the lives of Canadians. She lives in Toronto, Canada, and advocates for healthy living and a positive attitude for living with lymphedema. I'm very pleased to introduce you to her. Welcome, Anna.
Hi, Bonnie. How are you? Hi, everybody on board.
Very well.
I'm very excited to be the host of this new series. My role as editor-in-chief of Pathways means I work primarily behind the scenes and online, coordinating author submissions, editing, writing, getting ready for publication. Rarely do I get to actually speak with people, either authors or contributors, and definitely never with our readers. So this is a unique opportunity to connect with our readers, which is very exciting. Today's topic on evidence-based risk reduction recommendations is an extremely important topic and one that's very dear to my heart. When I was first diagnosed 20 years ago, about all the literature I could find about how to manage my lymphedema was a daunting, long list of do's and don'ts. I don't want to minimize the important role that those first guidelines had for the lymphedema community. And we certainly have Saskia Theadens of the National Lymphedema Network to thank for that first information. But we know that since then, science has evolved so that some of the earlier recommendations can be backed by evidence-based research, and some simply cannot. I'm honored to introduce Cheryl Brunelle, who I got to know better while we both worked on the risk reduction team at the LANA and American Cancer Society Summit in Missouri. Cheryl is not new to the Canadian Lymphedema Framework, as she's written for the Pathways magazine before and presented at our conferences. We appreciate, with her busy schedule as a full-time clinician and researcher, that she's taken the time to join us today. Cheryl is a physiotherapy clinical specialist and certified lymphedema therapist at Massachusetts General Hospital in Boston, and also the associate director of MGH Lymphedema Research Program. She specializes in treatment for individuals undergoing conservative or surgical management of lymphedema and lipedema. She's a strong proponent of lymphedema screening as standard of care. The MGH lymphedema screening program has screened over 8,500 women since its inception in 2005. Cheryl is widely published and frequently presents her team's research. She's collaborated on multidisciplinary teams to update national and international guidelines for receiving the COVID vaccine after lymph node removal, risk reduction measurements, diagnosis, and treatment of lymphedema. Cheryl is a primary investigator on a new prospective study at MGH on breast edema, and she's also researching measurement and screening tools for lymphedema. What you might not know is that Cheryl was born in Burlington, Ontario, and received her education at the University of Toronto. She still crosses the border regularly to visit family, so please join me in giving Cheryl a very warm Canadian welcome.
Hi, Anna.
Hi, Cheryl.
Nice to see you. How are you?
You too. Hope you had a great weekend. Your weekend was just last weekend. Ours was the week before.
I know. Happy Canada Day.
Yes.
So it's such a pleasure to be here. Thank you for having me again. It's a pleasure to do it again. And I'm really thankful to the CLF for always thinking of me and including me. It means a lot to me to be part of this first episode, especially in Canada. It's home for me. So thank you. It's nice to be here.
Well, we're honored. Cheryl, before we get into some of the questions, so the audience can get to know you a little better, perhaps you can just spend 2 minutes sharing what a typical workday might look like for you, since you wear so many hats.
Yeah, I count myself as very lucky as a physical therapist, because I don't think there are very many of us who can really balance or have the opportunity to be heavily involved in research and supported doing that at work, as well as manage a clinical practice. So I'm responsible for the staffing and oversight to see patients with oncologic diagnoses at MGH. So this could be lymphedema, lipedema, radiation fibrosis, deconditioning, any of the sequelae of cancer treatment. So I'm responsible for that. I see patients myself every day. And as well, I'm the associate director of the MGH Lymphedema Research Program. And this program was started in 2005 by Dr. Alphonse Tegian, who is still the director of the program. I'm the associate director. So we use our research, we do prospective research. We always have some papers on the go and some grants on the go and some studies on the go. So we always have something, quite a few things going on. So that's how I balance my week and my day.
And when that day is over, and the evening maybe, what are 3 things you like to do when you're not working?
I have 2 boys, so I like to spend time with them. We really enjoy traveling a lot. My husband's from Ireland and I'm from Canada, so we have some wonderful places to visit and to see. And we also include living in New England. We have the beach here, and in the winter we have skiing here. So we have a little bit of the seasons to enjoy as well.
Sounds like a great spot.
Yeah.
So can you set the stage and describe the background in which the team came up with the material in the risk reduction consensus document? We both know it was much, much more than the 3 days at the LANA Summit, with a lot of extensive work done both pre and post the meeting.
Yes, that's a really good point. This was very much a multi-year process, and a lot of this happened before the summit and before my time. I was invited to the summit, and that's when my role started. But for years, healthcare professionals have been giving these risk reduction guidelines or providing this risk reduction education to patients. And there are guidelines to this end from multiple national and international organizations, but many of them are more than a decade old. So LANA, for example, their original guidelines resulted from the ACS, the American Cancer Society Summit in 1999 in New York City. So these guidelines were older, and I'm the same. I don't want to minimize the original guidelines that were really very benevolent and based on clinical experience at the time and our knowledge of pathophysiology at the time. They were really meant to try to decrease risk in this population, but they need updating. Lymphedema research has exploded. LANA saw that, and LANA went ahead and collaborated again with the American Cancer Society and invited 75 stakeholders and content experts to St. Louis in November of 2023. And that's when I really met you and got to know you much better. It was really an amazing few days. But I think we need to take a step back and understand that these guidelines by several organizations also contradict each other. And based on the evidence that's available now, this group could come together and develop a set of guidelines based on that. So this was a 3-day summit. And during the first day of the summit, we listened as the status quo of the research was presented. So in 7 different themes. And one of them is risk reduction. And that's what we're here to talk about. And Julie Hunley, David Doublestein spent a lot of time before the summit reviewing the research and what is the status quo and presented that day. And then went away after the summit and wrote up a very extensive review of the status quo of the research published in Medical Oncology. So that paper writing was a good year after the summit that they worked on that. So there was a lot of time put in after it as well. The second and third day of the summit, we broke out into workshops, and one of them was risk reduction. And we spent a lot of time together as a group. These are great pictures of us. And Anna, you remember this being the manager of the wall of many Post-it notes.
Manager of sticky notes, my favorite.
Manager of sticky notes. And there were things upon which we very much agreed as a group. There were things we maybe needed to discuss, and there were things that we really didn't agree on and needed a lot of discussion. So we spent time on every single sticky note, the language of it, whether or not it was included, and what the evidence was behind it. And we went away and spent the next year as a group writing the guidelines, writing the recommendations paper, and then published that in Medical Oncology. So I really can't stress enough respect for LANA and the American Cancer Society and the due process of this. This was very much a Delphi process. There was unanimous agreement, and there were researchers, academics, clinicians, and I think even most importantly, patients around that table. And they have a voice that, for those of us who've not been patients with lymphedema or at risk of lymphedema, that's really important. So there was a lot of due process and care taken with this, and this was a process of many years.
Great. How crucial was it to determine what would and what would not be included in that consensus document?
So the committee decided that we were only going to include recommendations that could be based on the evidence, that could be evidence-based on current research. Otherwise, we would not include recommendations based on clinical experience alone or expert opinion alone. So our team at MGH is really a firm proponent that proof drives clinical practice, and that's how we approached these guidelines. There had to be evidence to back the language in them. We wanted them to be clear, concise, and user-friendly, and hopefully we obtain that for not just the patient, but the clinician as well.
So the literature review, which was amazing and so comprehensive, that was presented the first day before our group was to work on the recommendations. Were there any elements in that literature review that surprised the consensus team?
Yes. There were many times those second and third day, and you can remember this, where we said, I'm not sure that's what the paper said. We should open that paper up. And someone would bring the paper up on their laptop. We would read. We'd bring the statistical findings up specifically. And there were a few instances where the conclusion of a paper actually was not supported by the statistical findings in the paper. I think that's a really good point, because when we as clinicians are reading these manuscripts, we need to be reading the statistical findings, the methods, and the conclusions, not just the abstract, not just skimming the discussion. We really need to be paying attention to what the study actually found. We were also surprised a little bit, not entirely surprised, more disappointed that all of the literature is around breast cancer. Mm-hmm. And that's where the work's been done. There are so many patients who are at risk of or who have lymphedema from other cancer etiologies, head and neck, melanoma, gynecologic cancers, prostate cancer. There's a lot of work that needs to be done there. So we really needed to keep the recommendations specific to breast cancer until we have more information.
Yeah. Were there any particular recommendations that required more discussion among the team than others before consensus was reached?
Oh, yes. There was a lot of discussion about blood draws, injections, and blood pressure measurements. And this has been a contentious issue for a long time. Patients have been told not to have those medical procedures on the arm at risk of lymphedema for decades. And again, that was well intended and based on our knowledge at the time, but there is different evidence now. So we really needed to look at that. And when you examine the evidence, there are only 4 prospective studies that have found an association between any of these behaviors and lymphedema. One is on neoadjuvant chemotherapy, one is on sauna and lymphedema, and one, which was ours, that found an association between cellulitis and lymphedema, and that we're not the only group to have found that. But the only prospective study to find an association between injections or needle sticks and lymphedema was a 2005 study, so 20 years ago at this point, in a population very different in terms of breast cancer treatment than what we would see now. And the study was based on 8 patients who developed lymphedema after hospital skin puncture. And lymphedema was unfortunately measured in 3 different ways in the study, including subjectively by a healthcare professional. I don't want to minimize the experience of 8 patients with lymphedema, but this is a very old study and the number is very small. And the measurement of the primary outcome was not done well. I would say it was done well at the time with the information we had, but we know more now. So we painstakingly reviewed the research in this area. We discussed it a lot. I'm really familiar with this research. Our group at MGH has published 3 papers in this area, 2 in the Journal of Clinical Oncology, or JCO, and 1 review article in Lancet. And the 2 papers that were prospective in JCO, one with a sample size of 632 and the other one with a sample size of 327. So in our cohort at MGH, we found that blood draws, injections, blood pressure measurements, and number and duration of flights, air travel, were not associated with lymphedema. So our group, you remember, did not take this discussion lightly. There was a lot of discussion. I felt like I wanted to sit back a little bit and let that discussion happen because a lot of the research came out of our research group at MGH. And after we reviewed and discussed, the recommendation was unanimous that isolated blood pressure measurements, blood draws, and injections are not associated with lymphedema, have not been shown to trigger the onset of lymphedema specifically for those at risk.
Right. So on that vein, can you explain or clarify the difference on the recommendations for those at risk and those that already have breast cancer-related lymphedema when we talk about blood pressure cuffs and blood injections?
It's a really good point. We don't have evidence around the safety or lack of safety of those medical procedures on the arm with lymphedema. So for a woman who has lymphedema after breast cancer, there is no study to say that those procedures are just fine in that population. We haven't looked at it. I don't know that we ever will. We certainly will never have, understandably, a study that randomizes medical procedures into an arm with lymphedema. That would not get through ethics, nor should it. So the recommendation is to avoid, if possible, avoid blood pressure measurements, blood draws, injections, and infusions on the arm with lymphedema because we simply don't have any evidence to say that it's safe.
You mentioned earlier that a lot of discussion was around the flying and air travel. So does flying trigger lymphedema? What do we tell at-risk patients if they travel by plane and think they might develop it? Do they need to wear a garment? And is it proven to reduce the risk?
So flying and lymphedema, there are 3 level 2 studies, 3 level 3 studies, and 1 level 4 study that have found that flying does not incite lymphedema. There's only 1 level 4 study that found it did. This is a 30-year-old study in 1996. It was a questionnaire-based study, and 6% of respondents with lymphedema said they took a flight before their lymphedema. So it is a really weak study. only because it's 30 years old. I don't want to discount the evidence at the time, but it's really a 30-year-old study with a very small number of respondents with lymphedema after flight. So we don't recommend prophylactic garments for flight based on the evidence. I will say for anyone who's wearing compression on a flight as part of a routine maintenance, if they have lymphedema, for example, that garment should be really well fitted. It should be well fitted by someone who is used to fitting compression garments for flight or just routinely.
So outside of travel for regular day-to-day regarding prophylactic compression, the recommendation states that it may help prevent breast cancer-related lymphedema in people at risk. What are those high-risk elements?
So there was a really nice recent study on this by Vincent Paramanandam and his group, and he's now at Macquarie University, part of the ALERT program in Sydney. And they randomized 300 women at high risk of lymphedema. And specifically, they defined this the way they should, which is high risk being patients who underwent axillary lymph node dissection for breast cancer, as opposed to those who underwent sentinel lymph node biopsy alone. We know that node dissection is the primary driver of lymphedema risk and carries about 3 times the risk of sentinel lymph node biopsy. So they randomized 307 women to either postoperative compression starting day 1 until 3 months post their adjuvant treatment had finished, or no compression. And what they found is that there was a lower incidence of lymphedema. They followed for 1 year. There was a lower incidence of lymphedema in the group who wore compression, and a delayed onset of lymphedema in those who got it. So we decided to use the word that compression may help in those patients at high risk because the follow-up was only 1 year postoperatively. I know they're following this group for longer, so I hope we see longer-term data come out of this. And also, although they recorded it, there's not a lot of adherence data reported in the study. That would be really helpful to better understand the dosing that we might need to see with compression. They recommended the sleeve was worn 8 hours a day, but I don't know the adherence data. So we believe prophylactic compression may help. It should be a consideration for those at high risk after node dissection.
Okay. Temperature. There's hot tubs, there's saunas, there's high temperatures like today, the humidity. That's why I'm sitting in my living room instead of upstairs in the office because it's just way too hot up there. So can you clarify some of the findings and the recommendations between, climates, temperatures, saunas, etc., and what we had evidence for and what we did not?
Mm-hmm. And I think this is a really good point because so many people live in a hot climate all year. We're sitting in this 95-degree heat now, but what if that were all year? I don't want patients to avoid being outside if they could be outside doing something they enjoy. Some people enjoy being outside when it's 100 degrees. So it's an important distinction. And there's no evidence that hot climate incites lymphedema in those at risk. For those with lymphedema, there have been a few studies that have found that exposure to hot temperature may temporarily increase their LDEX score on bioimpedance, for example, or swelling in those with lymphedema, but it's temporary and it resolves. So the recommendation that we had was to just encourage patients to self-monitor if they were exposed to high temperatures. Saunas was different. There is a recommendation. We added the recommendation to avoid saunas for those at risk. This came from a really nice prospective study by Showalter et al. This was a sub-analysis of the PAL trial, Physical Activity and Lymphedema trial by Katie Schmitz. This was a randomized controlled trial of 295 breast cancer survivors. Participants reported their exposure to 30 different potential risk factors over a year, and the only risk factor to be associated with arm swelling was sauna use. So for that reason, that well-done study, we added the recommendation to avoid saunas for those at risk. They did look at hot tubs, and that was not found to be associated. So we did make the differentiation.
Right. I mean, a hot tub is not that different than people taking hot baths, which I do regularly. So the hot tub, there shouldn't be that much difference then. So what has your hospital clinic done to incorporate these new guidelines into daily practice? I know not the summer, but the spring issue of Pathways, we highlighted interview with you and Julie Hunley on the risk reduction practices, and also showed our readers some great material that your clinic has done. You've taken that pocket card that was part of the publication and added some lovely graphics and brought it down to patient level. There they are. They're great. So anyone that has received the spring Pathways will see what those clinical recommendations are that that Cheryl and her group has done. So what else has your hospital done to ensure that the recommendations, the updated recommendations, are now embedded into the information that's given out to patients?
This has been a challenge, I will say. Mass General Hospital is a huge facility. We have community hospitals. It's Mass General Brigham, so it's a number of hospitals. It's a number of community hospitals from Nantucket up to, Metro West Boston. So it's been hard to disseminate this. So I have tremendous respect for people trying to do this. One of the first things we tried to do is work with MGH leadership and administration to update the policies. It's really unfair to expect IV nurses or healthcare professionals to do a blood pressure on an arm at risk or to put an injection into an arm at risk when they have a specific policy that precludes them from doing that. So the first thing we did was work with hospital leadership on that. We were careful about the language of these policies. We adapted the guidelines into those cards that you so kindly included in the spring edition of Pathways. We wanted something that was really patient-friendly. We had it looked at for readability. They're larger print. There's some graphics. I think it's just more patient-friendly, and that was our aim with that. But we have a lot of work to do with this. It's really hard. It's hard to change the status quo. And again, these guidelines have been given, out of concern for the patient, and they're still online, and they will live online. So I think there's a lot of undoing to do and patient education to do, and provider education as well. A lot of providers aren't aware of these things. They have a lot to keep up with. So it's our job to disseminate them. We have a lot more work to do at MGH, though.
And not just you. We all do. We all take that responsibility. And whether it's a therapist listening who has their own private practice or who works as part of a hospital clinic or a patient advocacy organizations, the Canadian Lymphedema Framework, we all have the responsibility to take a look at the patient information that we currently have published, either on the web, either in our patient education material, and look at it critically and see what pieces need to be updated. And I'm still amazed when I look at many reputable websites for information that have not yet updated something as simple as the exercise. And we know that that's at least 10, 15 years ago, if not more, where the studies showed that exercise done in a progressive and a supervised manner are good for lymphedema. And yet I still see literature that says, try not to lift a purse or to vacuum. Yes, so some people might like to still have that information that they can give to their husband saying, see, I'm not allowed to vacuum. But that's old and has to be updated because that's just wrong and wrong information that needs to be, corrected.
And it's, I give Katie Schmitz's work with the PAL trial, which is what you're referring to,
Right.
was published in 2008 and 2009 in two of the highest impact journals I can imagine. She published in the New England Journal of Medicine and JAMA Oncology. I mean, they were tremendously strong studies and publications. And she disseminated and taught and lectured and has a Strength After Breast Cancer program, and still we see these things.
Yeah.
I can't imagine stronger evidence to tell us, to support us in asking patients to exercise and helping the patients understand it's important and to help guide them through that. So we're 15 years later and we're still trying. So that's a great example.
What do you think is the most important takeaway from this session?
I think, our group started this work. When I came into this group in 2014, and Dr. Tagan had already been starting this work. And he started this work because the team launched a survey to 970 women who'd been treated for breast cancer as part of Susan Love's Army of Women. And over half of those women told us in the survey that following these precautionary behaviors, this list of don'ts, as you referred to at the beginning as a patient advocate, had a negative impact on their quality of life. And to the team at the time, that just seemed unacceptable. You're giving this patient a gospel list of don'ts, and that's impacting their life. What is it based on? So we really started the work looking at this. And my hope is that updating these guidelines will empower women to take their personal circumstances and their personal risk and help make decisions for themselves based on these things, knowing the evidence and understanding what that is. When I talk about this at conferences, et cetera, I always say it is no longer okay to just accept the status quo. Proof drives clinical practice. We have to move forward. And I know when Dr. Tagan speaks of this, if we didn't let proof drive clinical practice, surgeons would still be doing modified radical mastectomies on everyone. Breast cancer treatment has come a long way because data has brought it here. And we could say the same of lymphedema. And I hope that patients feel confident looking at these recommendations to make personal choices and informed choices. And I hope the recommendations do just that and empower these women.
I couldn't agree more. When I was still helping out when I was working full-time still with the Canadian Lymphedema Framework and fielding some of the questions to like the helpline, the saddest thing for me was listening to patients who had lymphedema who stated, I followed the list of do's and don'ts. I did every single one of them, except for the one time that I stepped inside the hot tub or the one time I let a nurse, it's my fault that I have lymphedema. And it just saddened me that they thought they brought it on themselves and that they lived so strictly by this list of do's and don'ts. And I'm hoping that these new risk recommendations will free them up a little bit. And as you say, empower them to make better personal choices based on the information now given to them.
I think that's important. And one of the things I always try to tell patients I've met too many who've said that in our initial exam, and it's terrible when that happens. But I always say to that patient, your risk factors for lymphedema were in place the day you had your surgery. Mm-hmm. Your main risk factor for lymphedema was having those lymph nodes removed, and the surgeon did the right thing, and that's what he or she needed to do. But all of the other risk factors were in place the day you had your surgery. There's nothing you did to bring this on yourself. This was going to happen. Yeah. I think it's important that as lymphedema therapists, we say that because there are a lot of patients who articulate guilt over it when there's probably nothing they could have done.
Mm-hmm. Yeah, there's not many other diseases or conditions that people feel guilty about or think that they brought it on themselves. And it's just sad when I hear people talk that way. Mm-hmm. So I see we've got a couple of questions that have been submitted earlier and also from our readers regarding the webinar today. So here's a question. This question speaks to the timelines for lymphedema development. I had a mastectomy in 2012 and I do not have lymphedema in my arm. What is my risk at this point for arm lymphedema?
So I'm assuming this woman said this woman had lymph node removal, or else she wouldn't be at risk of lymphedema at all. You're quite far out from surgery, which is good. Your yearly risk would be low, which is about as much as we can say, but not zero. So in the longest series we have by Petrick et al., they found that lymphedema risk after about 5 years is about 1% per year, so really low. But I will tell patients stay vigilant about it. It's unlikely to happen. When I see late lymphedema happen, typically I see a trigger. like there's been an infection, there's been a tremendous trauma to the limb, something like that. I'm really curious about why lymphedema happens late in a very small number of people. Um, I'd like to study that. We just need a lot of it. We need a lot of that to study it well. But I'm very curious as to why it happens late. I have a couple of hypotheses. One would be just our system ages, like the vascular system ages. And in most people with really late lymphedema, I tend to see that they're older. I don't know. I'd like to know more about that.
Mm-hmm. Mm-hmm. For me personally, it was 5 years after cervical cancer. And I think I know what triggered it. I was working for Indigo at the time, and we were putting in a brand new policy for HR policy for all of the agents. They called them agents, but they were the retailers on the floor selling books across the country. And this is a long time ago, so bear with me. The recommendation was that you had to wear stockings then still. And so I thought I was quite smart, thinking, okay, well, I'll wear nylons, but without toes, so you can still wear open toe sandals. But those nylons, you have to wrap them around your toe. Little did I know that I think that's what triggered it, because I wore those the first day. The next day, woke up with huge leg, huge foot, and that's how I think my lymphedema started. It was like a tourniquet around that lymphedema leg, around the toe of that lymphedema leg. So that might have been the trigger. But yeah, I would love to read more about why people 5, 7, 10 years later, as you say, the risk factors are all there already the moment you had the surgery and all the lymph nodes removed. But then why is it much, much later? What is the trigger that suddenly brings the onset of swelling on? Very interesting.
I think it is interesting. It's also, and I don't mean to minimize the emotional impact of early lymphedema either, but when someone is through cancer treatment and is doing really well from a cancer standpoint and is 7, 10 years out and then has to deal with lymphedema, I feel like it's emotionally even harder at that point, because she really thought this wouldn't happen.
Yeah.
And now she's dealing with this again, and it's a constant reminder of the cancer and its treatment. So I feel like the emotional impact of that is even more so than for patients who develop lymphedema early, which is also a tremendous emotional impact.
Mm-hmm. Just like secondary lymphedema, I think, is tougher than primary, because a lot of these primary lymphedema patients, if they were diagnosed or if it's within their family and they've seen others and they've grown up with it, they've had a long time to manage it, deal with it. And yet the secondary lymphedema patient, as you say, they've gone through cancer, they've gone through that entire journey, they think they're over it, and then suddenly this happens. Another question here is, does a patient with sentinel lymph node biopsy of more than 5 nodes removed need to practice risk reduction?
So we have found in our group that it's not the number of nodes removed, it's the surgery type. So in terms of breast cancer, it's not the lymph nodes removed, the number of them. It's whether you had a node dissection or a node biopsy. So node dissection infers 3 times the risk of lymphedema as node biopsy. So we published in the Journal of Clinical Oncology a cohort of 1,815 women. And in that publication, we found 5-year cumulative incidence of lymphedema in those who had node dissection to be much higher. And those who had sentinel lymph node biopsy, this particular example, the cumulative incidence at 5 years was 8% after biopsy alone, and just under 11% with lymph node biopsy plus regional nodal radiation. So it's individualized. I tell patients with sentinel node biopsy, you're at low risk, but you are not at no risk. So you teach the same things, and it's really a very personal decision about what medical procedures that patient has on her own arm and about what risk reduction she wants to manage. I've seen patients with sentinel node biopsy who've developed lymphedema, so you do want to be vigilant about it, but it's very personalized.
Mm-hmm. There's a question live actually in the from someone related to this question who had 6 nodes removed with breast cancer treatment, but already had leg lymphedema during that. So they're asking if they have increased risk now for upper extremity lymphedema.
Can you repeat that, Anna? I'm sorry. I want to make sure I understood that.
I think I'm reading it right. I had to read it
Yep.
twice myself. So they had breast cancer treatment.
Uh-huh.
Had leg lymphedema while they had the breast cancer treatment and had 6 nodes removed with that breast cancer treatment. So now, does that increase the risk for arm lymphedema, upper extremity lymphedema, because they already had leg lymphedema?
So I'm assuming the leg lymphedema might be primary?
I don't
I
know.
don't know.
Yeah.
The leg lymphedema might be primary, but in any case, having lymph nodes removed as part of breast cancer treatment, that presents the risk for lymphedema of the upper extremity. Yes. If that's superimposed on a primary lymphedema, that risk could be higher. We really don't have much information about that. I would assume that risk may be higher.
Mm-hmm. Is it possible to manage arm lymphedema well with therapy, garments, exercise, and weight management?
Very much so. The word is consistency. Whatever treatment is indicated, just do it consistently. And I say that, and I say to patients, it's not easy. It's 100 degrees out there today, or I don't do Celsius anymore, sorry, but it is hot out there today. And I'm the first one to say wearing a stocking, wearing a sleeve in this weather is hard. But if you really want to control your lymphedema and keep it controlled, consistency is key. And conservative management works really well when it's done before really late stage lymphedema.
Mm-hmm.
Don't leave it, because I will tell patients at some point that tissue will start to change and we're very challenged in treating it. If we can get to it in stage 0, stage 1, even early stage 2, we can be quite successful treating it with the things that you listed: compression, exercise, self-care.
And I would say of all of those, I swear by compression and promote and advocate compression all the time. I mean, I wake up in the morning, brush my teeth, put my stocking on. At night, brush my teeth and take my stocking off. And I've been doing that for 20 years. And I just, I know the slippery slope. If you miss a day or two, or try to maybe go without for a fancy event, or, well, it doesn't look too bad, so maybe I can go with lesser compression or try something else. Then I just have to go back to the same consistent therapy or compression, the level of compression in the garment that my leg is used to. And as you say, on a day like today, it's extremely hot, but without it, I can't imagine with this humidity today what the leg would look like if I was not wearing compression.
Agreed.
Let me just see if here's another question that came in. Has the NLN updated their risk reduction guidelines yet based on this?
That is currently being worked on. I'm actually chairing that committee right now, and we're in the writing process right now. And looking to that. The NLN is really trying to get their guidelines updated as well. It's those guidelines are used really frequently, much like the LANA ones are. So it's important to update them. And we talked a little bit about this when we were writing the LANA, and part of the conclusion of the LANA paperwork was that we encourage other organizations to align.
Mm-hmm.
The evidence is the same, no matter what organization is looking at it. My hope is that we can get these recommendations to better align, and these frameworks and organizations to really be consistent with those.
Mm-hmm. And the pocket card that was included in the published article on risk reduction recommendations was really designed as a pocket guard for physicians and clinicians, that they could literally put it in their pocket. That is the one that Cheryl and her group adapted, but the original one in the article in the spring issue, and we certainly encouraged everybody to read the not just the abstract, but the full article as it was published in Medical Oncology, and we'll provide that link if we haven't yet after the show or after the chat tonight. Are there any other, I'm just going through some of the other questions that might have been asked ahead of time.
I'm just seeing Janet's, it says find Janet, but Janet's comment that patients need cancer rehab programs, including lymphedema risk management and management upon diagnosis. And speaks to Can Rehab, which is an initiative of 4 Canadian hospitals to offer cancer rehab to all Canadians. I couldn't agree more. I think cancer rehab needs to be holistic. And, when we screen at MGH for lymphedema, it starts the day of breast cancer diagnosis. We're measuring the arm at preoperative baseline, and that's really important. And we know the patient's risk factors for lymphedema when she comes back to us right after surgery. And that's when we really start to help her understand what her individual risk factors are and how that plays into her management and her decision and when she should call us. And part of cancer rehab and screening is to really empower the patient between those visits. So we can't be with the patient every day. She needs to understand what to look for and when to call us and know that there's assistance there and there's care available to her. If she doesn't call and we don't see her for 3 or 6 months, that's really not helpful. It's our job to help her understand when to call us.
And we know that there are a lot of gaps in care across Canada, also within the US, around the world. And one of those gaps is still prospective surveillance, is every clinic and every cancer center, integrating that into the protocol for breast cancer patients, for any patient, but specifically in this case, since tonight we're talking about breast cancer, and your group has done an awful lot of work on that as well. In fact, you've written and presented on that in the past.
Yes, and I always say now that, the NCCN, the NLM, the ISL, the ILF, I could go on with the acronyms, the ASBRS, all of them have guidelines in place saying that one should screen patients at risk for lymphedema, and that should start at pre-op diagnosis. So that is very important. It's no longer okay not to screen. You have all of these organizations with guidelines. It's what we should be doing. It should be standard of care. It's not easy. It's not easy to establish a good prospective surveillance program. And when there's very finite resources, which there are everywhere right now, it makes it harder. But I'm always of the keep it simple. Keep it simple. If you can just start screening for symptoms and you can take a few measurements and you can do an education packet, that's screening. You're starting somewhere.
Right.
Just starting small is great. And then proving that you can get that happening in your clinic and get, physician champions behind you. The surgeons need to believe in this. It takes time. We're still learning after doing this for 25 years. We adapt and we learn as we go.
A question that came in earlier before today was, is there any research on the efficiency of wearing compression garments in prevention of lymphedema during radiation therapy?
No, is the short answer to that. There isn't evidence about that. The problem with doing a study like that is that so many patients have skin breakdown or skin blistering during radiation. We're really not putting compression garments on at that time. I'm thinking of patients with breast cancer. You could put a sleeve on the arm, but I'm not seeing a lot of patients developing chronic lymphedema at the time of radiation. It's not what our median time of onset of lymphedema is, like 12 to 14 months out of surgery. It's not right when they're having surgery and radiation. So I can't see that really being an option unless you're talking about compression on the arm during breast cancer radiation. Patients are certainly not most of them don't wear a bra towards the end of radiation because their skin is so sensitive. So it would be hard to even do compression over the chest wall or breast for that patient.
Do we have any evidence on the effectiveness of pumps to reduce swelling in lower abdomen and legs?
We do. I do use pumps as part of my practice for select patients. My population is for the most part, quite young, quite active, and extremely busy. And I'm very hesitant to ask them to sit still for an hour on a pump, an hour that they don't have. The only thing they're giving up is sleep, which I don't want them to do. So for a patient who can't get into clinic, needs that, in between carryover at home of a pump, or for whom it's an adjunct already to a comprehensive program without them sacrificing something else, I do use pumps. I try them in the clinic. The vendor comes in, I try them with the patient. Some patients will say, I am not going to use this. Some patients love it. But I do try it in clinic to see how they respond. If there are comorbidities, I'm looking at their cardiopulmonary status while they're on that pump and how they respond before, during, and after. I think it's good to do that in clinic and just kind of how they like it before we order one for them. So yes, I do use them, but they're very much an adjunct. They are not a standalone. And unfortunately, I see them prescribed as a standalone treatment. They're only as good as the compression you're going to put on after them. If you're not using compression, I would say don't bother with a pump because you're getting this fluid potentially out of the limb and then letting it reaccumulate right back in again. So just being careful with that.
Yeah. Okay. I don't think there were too many other questions that are applicable to the entire group. Bonnie, were there any others that have come up that I might not have looked at on the screen? Because there's nothing wrong with us leaving a little bit early.
Hello.
Hello, Bonnie.
This has been wonderful. No, I think that
maybe people want to just leave a little earlier.
Well, we're pretty much right on time. So I just want to thank you for a wonderful conversation. I've learned a few things myself. I'll maybe just quickly surprise Grace by adding her to our screen here for a moment.
Yay!
Take a moment to,
Hi, Grace.
for those who don't know or have been receiving the emails about the links. This is Grace, our marketing and communications manager. She's been taking care of all of the behind the scenes stuff for us. So I just wanted to bring her up and say thank you to her. Before saying thank you to Anna and Cheryl so much for joining us this evening for this, and to our audience, thank you for joining us for this edition of Pathways Live. It looks like we've made it through to the end without any technical difficulties tonight. So especially thank you to Anna and Cheryl for being willing to come back and try this again for us. Again, we'd like to thank our sponsors for their generous support that makes these live stream webinars possible for us. I will say this is just the beginning. Pathways Live will be returning with more live streams soon, and we're currently putting together a full schedule, so stay tuned for updates and announcements in the coming weeks. In the meantime, we'd love to stay connected. If you have any questions, feedback, or ideas for future sessions, please don't hesitate to reach out. And on that note, I guess I'll just say thank you for spending your evening with us, and we look forward to seeing you again soon. Good night, everyone.
Good night, everybody.
Thank you. Good night, everyone. Thanks so much.
Take care.
Bye, everyone.